So it's a good time to introduce your lecture, Michael. So it will be your turn. So please develop in 15 minutes buttock injection, how to deal with complications. That's one of the key points.
Hello, everyone. I'm really honored to be part of as a speaker and a very important speaker. The thing is why I'm involved in all that. I'm the head of plastic surgery in of Sorbonne University, but we develop a service for other plastic surgeons and aesthetic medicine doctors that we call SOS plastic surgery to deal with complications of plastic and aesthetic medicine. Where they have problems, they can call us and send complicated and complex cases of complications. First, we have to say that IMCAS is very safe. The post-market study is really reassuring, and there is less than 1% of reported side effects. It's really, I'm very confident with the product. And IMCAS did a prospective study on 35 patients. It's not a big number, but it's still prospective. And we have less than 0.3 incidence rate for swelling, pain, redness, and it will resolve in within the 2 to 7 days. And really, the first thing, because I will speak about big problems, very rare, but big problems. So I don't want, I just want to be there to show that we can deal with big problems, and it's very rare, and it's really in the 0.1% of complications. And again, IMCAS is a really safe product. So as I said, it's very rare, but my specific experience, because of this new service we give to other surgeons and other doctors, we had 6 patients for 6 buttocks with 1 medical treatment we dealt with, and 5 surgical treatments to deal with this new entity. So this new entity, which is not a part of this usual complications, we were going to see the usual complications, very I would say not complication, but side effects. And we're going to see by the end of the presentation how to deal with, because it's most of you know how to deal with. But this complication, it's delayed recurrent hyperinflammation, what I call that. It's there is an inflammation triad with redness, pain, and heat, large palpable nodules and lumps, with recurrent episode of inflammation in different areas. It's fluctuating, as there is a swelling that spread in non-injected areas, and it's very impressive. And there is functional consequences, sometimes fever, anemia, and after the failure of plastic treatment that we're going to see, often we can, in these cases, we can say that this is this complication. So most of the time, 5 on 6 patients are more than 45 side syringes. The onset was 3 to 8 weeks after the initial injection, and usually patient and surgeons wait 3 to 2 months to be sure that that was a part of the follow-up. They were trying to help their patient, but probably we can do to treat our patients a little bit earlier to detect if it's this complication or not. The medical treatment started usually because there is no evidence-based medicine. Steroids, yes, but when you stop the steroids, there is a recurrence 10 days to 15 days after. Antibiotics, perhaps from an anti-inflammatory effect, but not for the antibacterial effect, and I will prove you why. Anti-inflammatory, in France, we are not really happy to use it, except on the very acute part, because the risk of infection, and to increase the risk of infection. So this clinical example, it's In this example, it's not the biggest case, and you will see biggest case. There was 25 syringes injected by side in one time, and she came with this kind of redness and lumpiness everywhere on the buttocks, swelling, redness. She had a fever, anemia, asthenia, and it increased with hot shower. And she was treated in the south of France as a very strong disease like necrotizing hypodermitis with very strong antibiotics, which had some very bad effects on her liver. So we decided to rule infection. So rule out infection. It's really important to rule out infection. So usually in this case, and you have to test it, CRP, it's high. So you have to know if it's an infection or an inflammation. So you go for a white blood cell count. If it's high, it's infection or steroids. Steroids in themselves are able to increase the number of white blood cells, sometimes 10,000. It's like an infection. So we still don't know. So we decided to use a procalcitonin, and if it's high, it's related to an infection. If it's low, it's related to inflammation, and it helped us a lot. So in this patient, she has a low PCT with high CRP and 10,000 white blood cell neutrophils, and she had no infection, and we decided to use hyaluronidase 3 sessions, and she had no problem anymore, except a post-inflammatory dyschromia. It's very classic, but she's quite happy. She has no recurrence for the moment. So why I'm pushing it on infection? With all the patients we had, with blood culture, because they had fever, and direct culture on the hyaluronic acid, we didn't find, even after 30 days, no bacteria, absolutely no bacteria, no fungus, no mycobacteria. So that's really important to understand that this state is not related to an infection, probably to inflammation. And again, you're going to give your patient steroids, and it will interfere with the number of white blood cell count. And PCT helped us a lot. PCT was low for every cases, and we didn't find any infection. And we need MRI in this difficult case. We are not able to treat our patient. All the treatment we have is the best imaging to me. It's not operative dependent, and we can see muscle injection. And I'm sure Sebastian could confirm that we can see we can see some injection within the muscle. And this is a fascial recta. How come hyaluronic acid could come here? It's a non-controlled injection. So my point is, it's not the product, it's probably the way it was injected. And as we see this HA within the muscle. We don't know how the degradation rate within the muscle. We don't know that. And perhaps we know, but it doesn't have to be here, as we see with Sebastian, we see with Massimo. So I think it's really important to control, and one of the key points will be ultrasound. And I said, as Massilio said, the cannula has to be rigid, and it's a really important point. So again, we see this kind of images, and really it's a T2 sequence. So this is in black, and even after 6 weeks, we still have this within the muscle. It's not normal. So I will stop with all this MRI, but just to show you that it was from my 6 patients, and you can see very strange images, and it's not supposed to be the site of injection of this material. So as you see, when we inject a lot of material, you can see it's spread everywhere in every part of the body, even on muscle. So I think it's very important to control the injection. So 4 and 6 patients had muscle injected, and this patient had still recurrence of inflammation 4 months after our surgical treatment that we're going to see. So we received this patient. She had 45 syringes per side, and she had these things. It doesn't look very impressive, but it was really painful. She was unable to sit, and she has pain, fever, and anemia. So we decided we could, at the beginning, we didn't know. So at the beginning, we considered like an infected implant as any implant, but we didn't have any infection in the blood. So we decided to take out a bit of hyaluronic acid. We did some punctures in the buttock, and we made a dilution of it. We tried to dilute it, the massive injection of hyaluronic acid, and we took out this hyaluronic acid, and we take blood and hyaluronic acid culture, and still no blood, no positive test. So by the end, it finished like that. It's not very beautiful, but she was better. But recurrent 7 days after, so she was really painful, again, very weak, the same things, and it happened on the other side, mild inflammation, and again, white blood cell count was 10,000. We stopped everything, antibiotics, steroid, and she still have anemia. CRP was 340, PCT was normal, so no infection. So we decided to treat her very seriously, and with this drainage, and we did washing through this drainage for 6 weeks, and she's really better, and it finished like that. And by the end, we had this kind of sequelae. It's very impressive. She lost most of the volume, most of the tension of the skin. But most of the problem is because she got muscle injection, and for me, this is the reason, she had recurrences of pain, not of fever, no, but she has pain. And she come and, oh, I would like to try another thing, but I have nothing to propose. And it's really, probably it's because of muscle injection. We did another MRI, and it was still HA in the muscle, and not in the soft tissue, not in the soft tissue anymore. And by the end, it was okay after a few months, but it was a very difficult time. And there was another case from a colleague, a medical anesthetic doctor, very good one, 25 syringes, and he has this kind of inflammation. He started to use steroids. He was not sure of any infection. He treated it with antibiotics, and it doesn't work for 4 weeks. And we decided to do the same treatment, but by the end we have to do the drainage, and she's way better. She has no muscle injection, so it was better, and she has no recurrences today. And you will going to see the final results. So we are happy to help them, but really it could be a non-controlled injection could be very problematic. So our hypothesis is hyaluronic acid could have inflammation, could induce inflammation, but there is a tolerance from the body. Perhaps it's because of non-sterile injection. There could be a biofilm, a colonization, and now it will start a constant stimulation of the T lymphocyte and entrapped HA in the muscle. So when they exercise, they have recurrence. So I'm not sure of this hypothesis. Really, it could be a delayed type hypersensitivity, but we are not sure. But we have to look a little bit further. Still, it's really rare, and we are working on this patient. So injection recommendation, I really, I couldn't be, I'm not the specialist of the specialist as Massimiliano, but so avoid anticoagulant, topical products that could give inflammation, avoid waxing, bleaching, anything on hair removal. Don't drink alcoholic, don't drink. You have to be trained, and this is the reason why we are here. Anatomy to know exactly where you want to inject, and maximum volume should be 75 milliliter. Be performed in aseptic conditions because we are afraid of the biofilm. Patient selection, as we saw, and avoid exercise and smoking at the beginning of the in the first week of the injection. Avoid exposure to extreme cold and heat. Avoid massages. We can apply a lot of things for the post-procedure recommendation, but really the most important thing is the aseptic. Know where you inject, and your ultrasound has to be probably the key point. So again, follow the indication for use, 75 milliliter per buttock maximum. Lower volumes for the next station if you want to, but the load of HA is really important because the degradation, the more quick you inject, the lower the degradation will be, and let the body acclimate to this volume, and avoid the muscle injection with the US guided injection. It has been done in orthopedics or in surgery with fat grafting, and muscle injection is a factor of recurrence. The classic complication, it's nothing to compare what we have seen with this new entity. So just to go through it, erythema, you can use steroid cream, bruising, heparin. Never use hyaluronidase in early events. Usually there is no problem after 7 days. Delayed adverse reaction. For migration and lumps, you can use hyaluronidase, but be sure you don't have any infection. If you have an infection, you can go with a steroid. Without infection, you can use steroid, anti-inflammatory, but be careful, and hyaluronidase. When you have infection, antibiotics for sure. Anti-inflammatory has to be discussed. Nodule injection of saline, as we did. Granuloma, steroid and anti-inflammatory. Granuloma with infection, antibiotics, and be careful with anti-inflammatory. And major infection with pus, antibiotics, and surgical drain. But again, what we saw, what I presented, was not infection. And it's a very, very, very rare complication. So this new pathology has to be known, and we saw that we could go through saline dilution, aspiration, and then drainage. Hyaluronidase, be sure you don't have any infection. I already said that. Sorry, it's a bit of a repetition. And thank you very much for your attention.
Okay, Michael, what discussion, because we can say that we can go step by step to clarify. Definitely, let's begin by the most easy question, and let's go on the difficulty of the question. Number one, and I think that Massimiliano can comment directly, the muscle injection. It's totally forbidden, so be very, very clear with that, Massimiliano.
It's a mistake. There is no other name to say that. It's a mistake. It's a mistake from the safety point of view.
And why now we have, and why we have that, from Instagram and many other publications, totally, out of control. The people, they inject inside the legs, they inject inside the muscle of the shoulders. And why they are doing that? Why they take a lot of big parts of risk? We cannot understand that. What's the point?
I think that there is no reason, both from the safety point of view and from the aesthetic point of view. When we inject into the muscle, we have a thickness and we have a pressure. The hyaluronic acid. The hyaluronic acid is not an implant. It's not a silicone implant. So anyway, the muscle will squeeze the projection. And so even from the aesthetic point of view, I really see no reason to do that. So in Instagram, you can see so many things.
Okay, so that's very clear. Now everybody know that it's totally forbidden to inject inside the muscle if you want to be safe. The point is the training learning curve and how to avoid, to be on the muscle. We are going to be a little bit back to that because I think it's one of the key points. So please, let's begin by Sebastian. Sebastian, you are with us. I think it's important that you comment that point. What, concerning the point of view of the anatomy, could be the number one recommendation to avoid to be inside the muscle?
So the thing is, there are multiple ways to avoid being inside the muscle. One of the things is you can do ultrasound guided, and there are a couple of studies that have shown that can do this to avoid to be inside the muscle. The other thing is you can account and calculate the depth, and then you can assume based on the angle that you don't go into the muscle. Because the tricky thing is when you advance your cannula, you don't feel the transition between fat and muscle. It's very easy to advance into the muscle. So I think these are two possibilities to account for this one. But if you do it completely blindly, you have to assume that there is a risk that you are inside muscling with this close to other structures.
Yes.
Yes. The easiest you can penetrate, and the high probability you can be in the muscle, because it's not a easy plane to be in this very densified fat. If you go easily, you will be under the muscle. It's if you cannot find an easy path, you have to be careful, really careful. I don't know what you think, Massimilian, but if you go fast,
I agree. I agree. Firstly, when one starts, has to be careful and do slowly. All the movements have to be really slow and precise. You enter, you press, and you feel your cannula, and you go and you inject, and not going with the speed of a Ferrari. Things are learned slowly. Then by the time you can be faster and safer. And the suggestion is to be parallel to the skin. More parallel to the skin you are, more you feel the cannula, and more safe you are. This is practical.
You mentioned, that we need any time to touch with the contralateral hands the cannula. Could you comment that? That's one of the key points.
Yeah. It's like in liposuction. When we perform liposuction, this is the skin. We put the hand over, then we enter the cannula. We feel our cannula and we feel the tip. Start to play with the tip in order to feel it. And when you feel on the surface, go back to the parallel line, go a little bit under, and then start to inject. Always feeling of cannula. This is the control, the clinical control, without echography, if you don't have any.
Okay, so we could say that we can feel with your finger, and you can feel with your eyes under the skin with the ultrasonographic system. So two mode of feelings, right? Okay,
Yes.
So now let's go to something with a much more difficult, and that's the beginning of the key question. Because, Michael, you mentioned different cases, and I was a little bit impressed at the fact that the last cases was quite well injected, 25 syringe, so it was not the 45. And you have said us that it was no one dedication to the muscle, meaning everything concerning the MRI was out of the muscle. So how you would like to explain this case? Difficult for you, huh? And for everybody.
For everybody, but in this patient, she has an injection more located in the upper area, probably the load in the same region. And as I said, the degradation of the HA and the tolerance of the body for much, even it's 25, but it was 25 in not everywhere, not spread everywhere. It was more in the upper external quadrant. So probably this is the reason. But again, it was injected probably not in the perfect sterile condition. I don't know. But again, the biofilm hypothesis could be an answer for why it happens and why there is this constant inflammatory state. and why it happens sometimes, and it's spread over the region which have been injected.
Okay, now let's go to the level 3 of difficulty, because one, we know from your deduction, your analysis, that the most part of the time, what you have mentioned now are not coming from the bacterial side. And that's something which is, of course, very new, very surprising. And everything is related to the inflammatory stimulation process. So the point is that how to manage that. And you say that you are not so dedicated to the anti-inflammatory treatment. That's the point. So the unique point you go, it's to go to washing, to make the drainage, to everything which seems to be, of course, adapted to the difficult cases when we are at the last at the last term. But before, how to manage that? Because the point is that you are not so convinced about the efficacy of the antibiotic, and you don't want to recommend the anti-inflammatory medicine. That's the point.
So if I have to give a part of advice, is first to be sure there is no infection, then you can go on steroids and hyaluronidase. That's yes, you can give this kind of advice. But the problem
and then that's the PCT. The PCT needs to be normal.
Yes,
one.
and it's really important. It's a very nice tool to use. But again, steroids could be interesting to avoid this very high inflammation, very important inflammation. And hyaluronidase will decrease the load of hyaluronic acid and will help the body to accept this hyaluronic acid. But again, I don't have the clue, and it's very rare, and it's not the normal complication. And we have to do some further investigation to see why it happens. But for the moment, that are my hypotheses. Biofilm.
Okay, Massimiliano, comment and recommend. Comment and recommend.
So I strongly believe that most of the inflammation that we may see are due to biofilm, and biofilm cannot be detected with a normal culture. It can be detected with microscopies, and so it's difficult. But I really have the feeling that most of the cases are due to that problem. I use hyaluronic acid for buttocks since 10 years, and the volume I injected quite mild compared to sometimes what we see around, and my complication rate is very low. I mean, I had nodules and lumps, of course, because I do the bolus, but nodules and lumps, you really fix it really easily, or by squeezing, or by aspirating, or entering inside the nodule with some hyaluronidase and aspirating. I never had the one case with inflammation, but one day maybe we'll have it, so I'm really aware about that. But I think that if we work in a sterile, with a sterile environment, and we do whatever we can do to do it in a proper way, we reduce dramatically the possible incidents. And then you said, Michel, you said another thing that I totally agree. I think that if one wants to inject volumes, I mean, big volumes, doing it in several stages is definitely more safe than injecting everything in one step. Even for body reaction, you do one step, and then you wait some months, and couple of months, and then you do the second one, and then there is an adjustment of hyaluronic acid, and then you can do it and then pop up the result. And I feel that it's safer than injecting big volumes.